Good evening, everyone. Thank you so much for taking an hour out of your day to spend with me to learn about the aging effects on the eye.
My name is Dr. Alpa Patel, and I'm a comprehensive ophthalmologist. I joined Gavin Herbert Eye Institute in October 2024, and I'm very happy to return to UCI, where I completed my undergraduate studies. I care for patients with a wide variety of eye conditions, many of which we'll be discussing today.
Real quick, we're going to talk about signs and symptoms. We're going to talk about causes and risk factors. We will review the treatment options. Of course, we'll talk about prognosis and course. I'm planning on spending about 10 minutes per topic approximately, and then that gives us about 5 minutes after each topic to go over any questions that you may have. I, I think you were invited to submit questions via the chat. And if I will respect the 5 minutes because I do want to end at 8 o'clock for those who only planned an hour for this evening. If there are more questions, I'm happy to stay as long and as late as necessary to address them, however. And also, please keep in mind, many of these topics will be covered more in depth over the year as we are having a community lecture up once a month. So never fear. What we will discuss today is ocular surface disease, glaucoma, cataract, and macular degeneration. So, going back to the anatomy, just to get a lay of the land, ocular surface disease affects the front of the eye, so the cornea, the eyelids, and the conjunctiva. Glaucoma is more around the pupil area. It involves the fluid and the outflow. The cataract affects the lens of the eye, the natural lens of the eye, and then macular degeneration is in the back and the retina over here. So we will start with ocular surface disease. Um, Again, it's actually a family of diseases. It's not one disease per se. Uh, the three most common, there's others, of course, but the three most common is blepharitis, which affects the eyelids, meibomian gland dysfunction, which are the little oil glands in the eyelids that make the oils that become part of the tear film, and dry eyes, which is the name that most people call ocular surface disease. And this is typically cause of either lack of tear production or quality of the tears, or tears that evaporate too quickly. So dry eyes, this is again the most common thing that people think of when they think of ocular surface disease. A little primer on the tear film. Our tear film is composed of three layers. There's the mucin layer, there's the aqueous layer, and there's a lipid layer. Dry eyes, it can be a poor quality or quantity of tears, and most of the um, interventions involve those two facets of the disease. It's exacerbated by age, gender, history of eye surgery, including LASIK and cataract surgery. So frequently people will come in after cataract surgery complaining of dry eyes. So signs and symptoms, dryness, irritation, contact lens intolerance, and what most people find surprising is tearing. Tearing is a very, very common sign of dry eyes, and that's because the body's trying to heal itself, so it makes tears. Blepharitis, it's inflammation of the eyelid margin, and it presents with sensation of burning or stinging of the eyes, crusty debris on the eyelid margin, irritated watery eyes, foreign body sensation, itchy eyes, and contact lens discomfort. Meibomian gland dysfunction, these little teeny glands make the oil film that become part of the tear film. And this is a normal eyelid here. You can see the little pores that are nice and clean and open. This is early disease, and you can see that the glands are getting a little stuffed up, kind of like a pimple, if you will. And you can see the glands are more visible here on the inside of the eyelid as well, whereas they're lighter in color on the normal. And this is advanced or severe meibomian gland disease. And the symptoms of this disease, burning sensation, blurry vision, short tear breakup time. Treatments. The good news is we have tons of treatments. There's our environmental and dietary medication adjustments that we can do. lubricating treatments, anti-inflammatory treatments, and treating meibomian gland disease. So let's start with number one over here, lifestyle. Balance it. That's always a good thing. You want to focus on leafy greens, berries. I like citrus. I think vitamin C is very important for the healing of the outer coat of the eye. Omega-3 is very important. You get that in salmon, flaxseed, walnuts, other fishes. You want to work with the weather. If it's a windy day like we've had the last couple days, you're definitely going to want to be mindful about wearing eye protection and using artificial tears before you leave your home. If you go to the desert, same thing. And you want to take regular breaks. We're all working on our computers quite a bit these days. Every 20 minutes or so, you want to take a break, look at something far away, blink a few times. That's also a good opportunity to put in some artificial tears, which is number two. Preservative-free artificial tears are a crucial part and probably the first intervention that most of us are going to recommend to our patients who complain of ocular surface disease. And we prefer preservative-free, which can come in little vials like this, single-use vials, or in specialized bottles. And that can be up to every 2 hours. Tons of prescriptions and procedures that we can do for dry eye disease, which is great. We're going to talk about that a little bit more coming up. And eyelid hygiene, always one of the earliest steps. Warm compresses or an eye mask. These can be heated in the microwave, or alternatively, you can plug them in, and then eyelid wipes to help cleanse the base of the eyelashes where those meibomian glands are. Medications, as I said, tons of options here. Topical steroids will decrease inflammatory components of dry eyes. Serum tears, this is when they come to your house and they take your own blood and they spin off the red blood cells and make the serum into preservative-free tears. The tear film is much more than the mucin, the aqueous, and the lipid layers that we discussed a few slides ago. There's a lot of components and factors and all sorts of things that are part of it. And using your own serum often is the best treatment for many patients. Cyclosporin, this is one of the first categories of dry eye treatments that we had. We had Restasis as the oldest. We have Vivi, Sequa, and they're quite effective. They do take about 4 to 6 months to become effective. So it is daily, every day, twice a day. Xiidra is another one. You've got Triptyr, just came on the market in mid-August. Xdemvy, I'm sure you've seen those commercials on television about the mites. That's what Xdemvy addresses. Oral and topical antibiotics. This is not an infectious disease. However, certain antibiotics have an anti-inflammatory effect. And that's why you'll find that some of us may prescribe that for you for your dry eyes. And then topical allergy drops are helpful. Procedures. We do have a variety of procedures that we can do for ocular surface disease as well. Tear conservation is an important category. We can put in punctal plugs. There are little pores right in the corners of your eye right there. And we put little stoppers in those pores where the tears drain. It's kind of like when you're going to take a bath and you put this stopper in the bathtub to prevent the water from draining away so quickly. Same concept. There's a couple types. There's collagen, there's silicone. Collagen melts away with time. So that's a nice way to start to see if you like it. We also have Lacrophil and cautery, which lasts longer. IPL, it's an office procedure used to reduce inflammation of the eyelid margin. LipiFlow and Tear Care help open up those meibomian glands that we saw a picture of a few slides ago. And then BlephX is excellent for cleaning the blepharitis from the eyelashes. Bandage contact lens is helpful for severe dry eye disease. It just keeps the cornea protected from the elements. The important point on all of these is this bottoms line right here. There's no cure. These are all just treatments and it takes time. And for most people, it's going to be a variety of the interventions on the last few slides that are going to get you to where you're symptomatically improved. We're going to talk about glaucoma. Glaucoma is an issue concerning the fluid in the eye, which creates a pressure. Now, this is also a family of diseases. It's not one particular disease. I am going to focus tonight on primary open-angle glaucoma, which is the kind that affects older folks the most. And that's our topic tonight, is aging in the eye. It's also the most common type in general. And it's a chronic disease. It damages the optic nerve due to the increased pressure. And the optic nerve is way in the back of the eye. It's a gradual, painless loss of peripheral vision. So even at the end stage, people can have 20/20 vision. Unfortunately, it's more like a tunnel vision. And patients will find that they have to move their head around to see things. And what happens is that there's either too much production of the fluid in the front of the eye or inability of that fluid to drain through the eye properly. And that results in an increase in the eye pressure. It's usually bilateral. Risk factors include age, high eye pressure, family history of glaucoma, diabetes, nearsightedness or myopia, and ancestry. Lots of treatment options. Eye drops is where we usually start. And what they do, there's different categories. We have many drop options these days. They either decrease the production of that fluid or improve or increase the outflow of that fluid. We also have laser office procedures that we can do that also focus on improving the outflow. There are surgeries that we can do at the same time as cataract surgery called microinvasive glaucoma shunts, or you may know them as MIGS, M-I-G-S. And there's a variety of these different procedures. And what we do is we put a stent or a device, an ocular implant in the angle of the eye, and that improves the outflow. And then there's trabeculectomies and tubes, which are also shunts and or other mechanisms of improving the outflow. Here's a quick common thing that question I get with my glaucoma patients is, I'll ask if there's a family history of glaucoma, and inevitably people will say yes, but it gets confused with cataracts. So I wanted to take this opportunity to discuss the two and show you the anatomy. Glaucoma, again, is in the front of the eye. The fluid gets caught. It can't drain away like it's supposed to, and it increases the eye pressure, and it ultimately affects the optic nerve. Cataracts, it affects the lens of the eye. The lens here, it's clear as it's supposed to be, and here it's not clear, it's opaque. And so the light cannot pass through and people cannot see. Cataracts. This is one of the most common causes of decreased vision in the world. It's when the natural lens becomes opaque, like we just talked in the other slide. There are many different kinds of cataracts. Again, today we're going to talk about the age-related kind. And in this country alone, we do approximately 4 million cataract surgeries a year. So if you're having cataract surgery, you are not alone. Risk factors for cataract surgery, genetics. But in reality, honestly, everybody who lives long enough will get cataracts. It's like wrinkles and white hair. It is part of the aging process. There are factors that can bring it on earlier. For example, diabetes, obesity, certain medications, and trauma. And there's the environmental factors, smoking, alcohol, and sun exposure. Signs and symptoms of cataracts: cloudy or foggy vision. Changing glasses doesn't help. It's still blurry. The colors are not as distinct. Things are not as crisp. You may get glare or halos when you have headlights or points of light. Double vision that doesn't go away when you blink. Decreased night vision and sensitivity to light. Cataract surgery, changing glasses is effective as a mediating factor like early in the cataracts development stage. But ultimately, for most people, it will have to be removed and a brand new lens will have to be placed in the eye. There are options for standard or advanced technology cataract surgery. The laser cataract surgery is called femtosecond laser assisted cataract surgery, or FLACS for short. And there are options at the time of cataract surgery to address other things, for example, astigmatism and presbyopia. to decrease the dependence on glasses. A standard cataract surgery is a manual surgery. It's refractive correction will be needed afterwards, so either glasses or contacts, definitely for reading. And it's a monofocal intraocular lens. And in comparison, you have the advanced technology, you have the flex, the laser assisted. We can decrease astigmatism, which is something most people are born with. And presbyopia is when you need glasses to read. It happens typically in the late 30s, 40s for most people. And we can also do limbal relaxing incisions to decrease the astigmatism. Of course, this doesn't make anyone like a 10-year-old with perfect eyes, but it should decrease your dependence on glasses for most of your day. Let's move on to macular degeneration. And it's in the name, it's age-related. So risk factors, family history, age, lighter eye color, obesity, high blood pressure, smoking, sun exposure, and nutrient deficiency. This is kind of a pictorial of the progression of macular degeneration. And you can see in the first grid here, this line right here is a little faded, but otherwise it looks okay. You can see the young child's face, and this is progressing. The straight lines no longer look straight. They're a little wavy, and his face is getting darker. Now it's even worse. It's progressed. Face is getting darker, but keep in mind that this peripheral is pretty good. It's the same as in the original picture. And this is end stage or later stage where you can see the face is basically gone and the periphery is still intact. And there's a lot more warpage of the lines. And this is typically what a patient experiences who has macular degeneration. There's different kinds. I'm sure you've heard that there's a wet and there's a dry. The dry is the more common kind, about 90% of cases. There's protein deposits in the back of the eye and the macula. And depending on where they are and how many of them there are and what type they are, they can affect the clarity of your vision. And this typically takes time. It doesn't just come on overnight. It's a gradual development of these deposits over years. Medication, lifestyle, dietary changes, supplements can help slow the progression. It can become wet if left untreated, but usually it doesn't. And it progresses into 3 stages. There's early, intermediate, and late stage dry AMD. Now, wet is the one you probably hear of the most. These are your friends who are going in every month or so to get an injection with their retina surgeon. It's the rare form. It's about 10% of macular degeneration. However, it's the majority of the vision loss of these macular degeneration patients. And this is the growth of abnormal or new blood vessels in the fovea, the part of the eye that sees the best, that causes the macula to swell or bulge. It can develop quickly, days or weeks, and it's sudden loss of vision. There's special injections may prevent the growth of these blood vessels, and that's why your friends are going in and getting these injections on a monthly basis. Most of these cases start off as dry, and these are always late stage macular degeneration. These days, there's also some injections for the dry varietal. Treatment options, preventive is always best. Sun protection, sunglasses, leafy greens, berries, and omega-3. Same thing as you may remember from the dry eye. You want to stop smoking, maintain a healthy weight, manage other medical problems. You want to check your AMSA grid weekly. We give you a little grid just like I showed you in a couple slides ago with a bunch of squares within a square. And that's how you can monitor yourself at home to see if there's any changes. Your doctor may recommend an AREDS2 supplement. That's not for everybody or necessary for everybody, but in certain patients that may make sense. Low vision aids for people who have end-stage disease, they can go to the Braille Institute or other specialty offices and get some low vision aids. Photodynamic therapy, intravitreal injections, laser surgery. These are all treatments available. Adjustments in the home, they can modify your home to make it safe for you to be mobile and do your activities. Again, unfortunately, just like many of the other things we discussed today, there's no cure. So let me just summarize here. You want to look to your sources. You can go to urgent cares for any emergencies. Want to follow up with your primary care doctors for optimizing your general medical health and your family eye doctors to have preventative annual exams. And we're always here for you at Gavin Herbert for any specialized eye care needs.